Good morning, everyone. Still be a morning, right? My name is Dr. Jomjit from the Division of Medical Oncology, Department of Medicine. So my talk today will be immunotherapy in clinical practice and also touch base with immunotherapy biomarkers and a little bit with the mechanism of resistance and future immunotherapy. So here everyone knows that types of immunotherapy that I'm focusing on checkpoint inhibitor today. And the second one now is a very popular and goes so fast is antibody drug conjugation and also adoptive cell therapy, CAR T cell or CAR NK cell. I didn't know much because I'm a solid malignancy treatment and cancer vaccine and also cytokines. So since 2011, there are so many indications for immunotherapy until the recent day. So there are 5 to 6 agents to be approved in clinical trial and clinical practice now. So here is an example of a predictive biomarkers for checkpoint inhibitor response. The most used in clinic is a high PD-L1 expression score, which is TPS score or combined positive score, MSI high, MMR defect, or high tumor mutational burden. But however, there are only few biomarkers as established as general biomarkers for checkpoint inhibitor. However, the other immune checkpoint inhibitor biomarkers can be can be combined in a lot of clinical trials as a predictive biomarkers as well as the first 3 of biomarkers. For example, immune gene related gene expression, for example, interferon gamma signature, or high TILs, or LAG3, TIGIT, pol mutation, or something like microenvironment, like gut microbiome. So the question in clinical practice is, predictive biomarkers always predict response of immune checkpoint inhibitor or not? So before I go over the treatment, I'll talk a little bit about how to interpret the biomarker, the most important issue before use the predictor to predict the response. So now we have an FDA approval monoclonal antibody and its companion diagnostic test here, like clone of a 22C3, SP142, or SP263. However, there are some discordancy of the different assays between clone and also a scoring system. So here is a table of discordancy. So the pathologies need to be matched between the clone and the scoring system. So for example, within the TPS score positive in the tumor stain with the clone 22C3, you can see if you stain this tumor with SP142, there are only 63% of positive cells. So what is the problem in clinical practice? If your hospital lab, if your available test in your hospital have only 22C3 clone, but you need to use durvalumab, for example, that its companion clone is SP263. So this can be limited to select the right patient to use durvalumab because you don't have any companion test. But no worries for now, because a lot of pharmaceutical companies provide their companion test before using the monoclonal antibody, even though they are comeback negative and we don't use it, but it's free. So here, go back to that PD-L1 score, predict response from immune checkpoint inhibitor or not. So if you see this paper about adenocarcinoma of lung, the patient received pembrolizumab versus chemotherapy. You will see in every TPS score, expression score, the patient will get benefit from pembrolizumab over chemotherapy, regardless of PD-L1 positive score. However, in the patients with high PD-L1 positive score, the overall survival will be longer than PD-L1 negative or PD-L1 less than 50%. So this can answer the first question that, okay, for adenocarcinoma of lung, PD-L1 score can predict response from checkpoint inhibitor. But not quite for triple negative breast cancer. So of course that CPS score more than 10 is predict response and predict the benefit of using pembrolizumab compared to chemotherapy. But when we cut off at the 20, it's not different. So this one, the problem of this one is how to cut off. However, the patients who has a PD-L1 expression score more than 10, you can use pembrolizumab as a choice. And this is a controversy. This review literature tried to answer that the immune checkpoint inhibitor is beneficial for PD-L1 positive breast cancer in everybody. The answer is no, because there are 3 landmark trials in clinical studies show that not every trial has positive study. You will see Impassion 130, Impassion 131, they use atezolizumab in the patient with triple negative breast cancer who has PD-L1 positive, but the result of overall survival, one paper is positive, but the other is negative. Whereas in pembrolizumab study is positive for overall survival. So there's controversy that PD-L1 on breast cancer can predict the response from immune checkpoint inhibitor or no. So the third one is squamous cell carcinoma of lung, that all patients who receive pembrolizumab had longer survival than chemotherapy. However, PD-L1 expression score, it did not predict any response. What is the problem in clinic? If the patient have a lot of money, I will offer for everyone that, okay, everybody, if you have the money to afford immune checkpoint inhibitor, regardless of your TPL1 expression score, I'll use pembrolizumab for you. But if the patient has borderline financial, we cannot select how could you get benefit from pembrolizumab over conventional chemotherapy. And if you cannot afford, you want to cry or you want to go with chemotherapy. So there's something with the problem. So for prostate cancer, I think everybody knows that prostate cancer is low immunogenicity tumor, and maybe checkpoint inhibitor is not a choice of treatment, and not surprised that overall response rate is only 7% for PD-L1 positive prostate cancer. So the question is, do we stop investigating of a immunotherapy in prostate cancer and discard immunotherapy in this kind of tumor? So here is a retrospective study to demonstrate that actually immune checkpoint inhibitor associated with longer overall survival in metastatic prostate cancer if the patient has high tumor mutational burden. So when compared to conventional chemotherapy. So why don't we create the prospective study for the high TMB prostate cancer? So if you see the number of patients here, all population is about 600. But high TMB patients, there are only 30 patients with high TMB within 10 years experience in the big center. So this, because of very low populations to create the well-designed study for high TMB prostate cancer, but this is very promising. So this study is my favorite. So this called phenomenal study. The name of drug is dostarlimab. It is a novel and anti-PD-1 monoclonal antibody using in MSI high colorectal cancer. So for basic of disease or rectal cancer, if the patient has rectal cancer, normally we do radiation and chemotherapy to preserve the sphincter, because if not, we need to cut the tumor with the anal sphincter, and the patient will have colostomy permanently. So we try to avoid that kind of surgery. So this drug offered the clinical complete response, 100% of in 100% of patients. So how do they do evaluate the complete response? They do a colonoscopy and also PET scan plus MEDAS biopsy if available. So we've never seen this impressive result before. So this medicine is there are a lot of clinical trials that try to explore this immune checkpoint inhibitor. The second question is immune checkpoint inhibitor superior to conventional therapy for every FDA approval indications? The answer is yes, of course, because if it's inferior, it's not going to be approved. So, but there are some pain points for survival benefit here. If you see this is very, very clearly benefit from pembrolizumab over chemotherapy in terms of overall survival in non-small cell lung cancer. But the point is this first several months from the time of administration of immune checkpoint inhibitor, you can see the red curve, which is pembrolizumab. It's a bit lower survival compared to chemotherapy. Why this happens? This is the answer. So the median time to onset of action of immune checkpoint inhibitor is 2 to 2.5 or maybe 3 months. So if you have sick patients, if you have the patients with a lot of symptoms, tired, need oxygen for lung cancer, the patient cannot wait for this time. This is longer. It's too long. So you need to combine with chemo, or you need to combine with the targeted therapy, which is a faster onset of action. And also in the patients who are for intracranial, who are brain metastases, immune checkpoint inhibitor itself actually not penetrate to CNS, but it's immune cells that works in brain. However, there are many new novel PD-1 antibody that try to improve the intracranial activity, because PD-1 inhibitor or PD-L1 inhibitor has poor intracranial activity. So it needs to be cautioned in patients with brain metastasis as well. So there's a limitation of treat patients with immune checkpoint inhibitor. So what response index is the best? So we, as a medical oncologist, we use the scan. We use the symptoms of patients to see that the patient who received immune checkpoint inhibitor do response from the drug or no. If the scan smaller, the tumor on the scan is smaller, it's okay. We keep continue. But if not, if the tumor is bigger, or if tumor is a little bigger, it's a lot bigger, but the patient still well, still fine, do we stop? So normally, immune checkpoint inhibitor offer the progression-free survival, which is the interval from the start treatment to the first scan that show the tumor progression. It will be around 10 to 11 months that we need to stop treatment. But for chemo is a lot shorter. 4 months, we need to stop treatment. So at the time of scan progression, we need to stop treatment and talk to the patient that your failure of treatment or actually not. So before answer this question, this is a pattern of immune checkpoint inhibitor response. So if the patients are in the first two pattern of response, we call true progression and hyperprogression, which means after, let's say, the standard scan will be 2 months after administration of checkpoint inhibitor, and the tumor is get bigger. If it's bigger a lot and the symptoms of patients worsening, we need to stop treatment. It's called true progression. The symptoms of patient worsening, we need to switch therapy into chemo or target or any other. But if it's a third pattern here, we call pseudoprogression, which means the first 2 or 3 months, the tumor seems to be bigger, but actually the longer diameter of the tumor on the scan was replaced by the immune cells, but actually the cancer cells are dying. So we call pseudoprogression if the following scan is if the tumor on the following scan is smaller, but the patient needs to be stable and improve symptoms. So this is a very difficult when we do the clinical trials or when we do the research. We need to design the response criteria, not only the longest diameter, but we need to allow the patient to have pseudoprogression period here. So this is the detail for who is interested in response criteria. So for immunotherapy resistance, this is painful as well because we don't run NGS in every patient receiving immunotherapy, but actually genomic factors is one of the most important cause of immunotherapy resistant. So here is the immunotarget registry project that provide the knowledge that if the non-small cell lung cancer patients harbor specific alterations, for example, EGFR, ALK, RET, ROS1 within the tumor, the patient will not going to get any benefit from immunotherapy, and we will not treat the patient with immune checkpoint inhibitor unless the patient have no other choice. So, however, it's not every alterations. We can see some response in BRAF V600E mutation can get some response from checkpoint inhibitor. We can see MET amplification patients can get response. And also KRAS mutations can get response from immune checkpoint inhibitor. And another thing is a tumor heterogeneity and microenvironmental factors. There are different clone and different sites of metastases, different environment in the different organs offer the different response from immune checkpoint inhibitor. You will see this one that the patients will treat with checkpoint inhibitor here. The tumor is disappear in axilla, but there is a new spot here because of different clone, maybe different environment here on the different site. So how to overcome resistance? I think the researchers try to answer this question. Immunotherapy plus targeted therapy to close the gap of several first 2 months that the onset of action is too slow, or maybe IO target, maybe combination therapy. For example, relatlimab plus nivolumab. And luckily that this combination not cause very toxicity. This is good. So there are the right combination that toxicity of immunotherapy is very minimal or not different from nivolumab itself. However, relatlimab is LAG-3 inhibitor, but in the analysis show that LAG-3 is not predict the benefit of adding LAG-3 inhibitor, but maybe synergistic effect that's still ongoing. So this is the limitation of immunotherapy treatment in Thailand. The cost is the most important, the reimbursement. So hope for future is maybe domestic drug, but we need to face with ethic approval, the culture, oncology's confidence. So there are a lot of things. And here, the last slide is future direction. There are a lot of ongoing clinical trials at Siriraj Hospital that we are send the patient to participate. For example, anti-PD-1 plus chemo, anti-PD-1 plus targeted drug, anti-PD-1 plus anti-LAG-3 or TIGIT, and antibody drug conjugation, and also cancer vaccine, which is good response in hepatocellular carcinoma. Thank you very much. So any question from the floor, please?
Thank you so much. It's very clear, very helpful, and I'm sure the student love it. Just curious about the last one, the cancer vaccine. Can you give us more detail? What kind of vaccine?
I'm not sure in the detail, but it's kind of oncolytic virus that give to the patients with metastatic hepatocellular carcinoma, and then we scan to see the efficacy of the oncolytic virus. I don't know if I call it wrong as a vaccine, but they call it vaccine. Yeah, maybe peptide kind of. Yeah. Yes.
I think we have a question from the back of the floor.
สวัสดีครับอาจารย์จอม It's Dr. Nadanai from Immunology Department. So I just want to ask you about the direction and the situation of the utilization of the immunotherapy in Thailand and the future direction, because in like the US there are like the advancement in the immunotherapy, for example, they're now talking about like the bispecific T cell antibody and even the CAR T cell. So I just want to know how many or the opportunities of our country to get access to this kind of immunotherapy in case of the immune checkpoint inhibitors first. Thank you.
Thank you. I think the chance that the patient will get immunotherapy is in clinical trials from pharmaceutical company, and also so investigator initiation trial can be done too if we design protocol good enough that they're going to pay for the funding. But however, there are the high cost for immune checkpoint inhibitor, and I think in the future, maybe yes, after 10 years of, I think generic drugs are coming for some of immune checkpoint inhibitor, for example, pembrolizumab. Maybe in the next year or 2 years, we can see a lot cheaper checkpoint inhibitor than the recent day.
One more, please. Okay, so do you think if we can like in clinical trials and we can prove the efficacy in the Thai population, show the data to the government, do you think it is possible for them to approve for the uses of the immunotherapy in the universal coverage?
So it's difficult to answer because actually, even though we confidence to researcher that you have a medical grade immunotherapy, we have domestic. There are some belief, some confidence from the doctor who will send the patient to participate into the domestic clinical trial. I mean, monoclonal antibody that create by ourselves. So this is a lot of discussion, I can say. Yeah.
Okay, thank you.
Any more questions? There is a question from the online participant. One question. Yang, do you think the ongoing predictive biomarker discovery apart from L1 and TMB might help in patient stratification?
Of course, yes. So a lot of we call hot tumor or inflamed tumor. There are a lot of space to study about the biomarker for response of immune checkpoint inhibitor, and also the most interesting issue for now is how to convert cold tumor into hot tumor using some immune biomarker, or actually combine and to see synergistic effect between checkpoint inhibitor and other class of medicine, for example, targeted therapy. So now, for example, in sarcoma, they try to combine checkpoint inhibitor and target therapy like cabozantinib, which is not cabozantinib is a broad spectrum a tyrosine kinase inhibitor. It doesn't target any of oncology driver, but it's actually cover a lot, and the synergistic effect of immune checkpoint inhibitor can offer the great response in cold tumor, for example, nerve sheath tumor, leiomyosarcoma, which is normally not respond to anything. So this excellent study too.
So thank you for the wonderful talk. So I might miss your mention, but I was wondering, so what is the mechanism of hyperprogressive or progressive disease? Why those tumors progress more?
So I think one or two established mutation is MDM2 amplification within the tumor because of immunotherapy do something with this kind of mutation. So the tumor can have MDM2 mutation without any growth without the immunotherapy. But once you give something that boosts immune system, the tumors are grow so fast, and this one of the mechanism for hyperprogression. Yeah. I think there are a lot of mutations, but I can't remember what it is. But yeah, MDM2 is the most established.